I think our panel is seated. We'll ask those who are talking in the back to please leave the room. Sirs. Thank you. And I know the hour's late, but we do appreciate your being here. And I'm told we may also have another vote, so we'll see. We'll try to get through your testimony. This is the panel on insurer views. And beginning on my left is Howard A. Kahn, who is Chief Executive Officer for LA, I assume that's Los Angeles Care Health Plan? LA, okay. Karen L. Politz, who's Project Director for the Health Policy Institute at Georgetown Public Policy Institute. Karen Ignani, who is President and CEO of America's Health Insurance Plans. And Janet Troutwine, who is Executive Vice President and CEO of the National Association of Health Underwriters. And I don't think I have to tell anyone here that we try to keep it to 5 minutes, and your written testimony will be included complete in the record. And I'll start with Mr. Kahn.
Thank you, Chairman Pallone. Members of the committee, thank you. The need for national health care reform has never been greater. As the CEO of LA Care Health Plan, America's largest public health plan, I am here to provide information about our model and how a public health plan option has worked in California for more than a decade. LA Care is a local public agency and health plan that provides Medicaid managed care services. We opened our doors in 1997 as the local public plan competing against a private health plan, HealthNet of California Incorporated. LA Care strongly supports the concept that public plans can provide choice, transparency, quality, and competition. LA Care competes on a level playing field against our private competitor. Plans must have enough funding to ensure provider payments and operate under the same set of rules. LA Care has always been financially self-sustaining and has never received any government bailout or special subsidy. LA Care serves over 750,000 Medicaid beneficiaries and has 64% of the Medicaid market share in Los Angeles. The competition between LA Care and HealthNet has resulted in better quality and system efficiencies. For example, as part of our efforts to distinguish ourselves in the marketplace, LA Care attained an excellent accreditation from NCQA, validation that it is possible to provide quality care to the poorest and most vulnerable in our communities. There are 7 other public plans like LA Care in California providing health coverage to Medicaid beneficiaries. In all of these counties, the public plans compete against private competitors. 2.5 million Medicaid beneficiaries are provided health services through this model. California has other public plan models as well. Congresswoman Eshoo, a member of this subcommittee, is very familiar with the enormously successful county organized health system which she and I helped create within her district. Our provider network includes private and public hospitals and physician groups, nonprofits, for-profits, federally qualified health centers, and community clinics. Our subcontracted health plan partners include some of the biggest private health plans, Anthem Blue Cross and Kaiser Permanente, as well as smaller local plans. In addition to Medicaid, LA Care operates a CHIP program, a Medicare Advantage special needs program, and a subsidized product for low-income children. What makes LA Care a public health plan different? LA Care conducts business transparently. We are subject to California's public meeting laws, so all board and committee meetings are open to the public. LA Care answers to stakeholders, not stockholders. Its 13-member board includes public and private hospitals, community clinics, FQHCs, private doctors, Los Angeles County officials, and enrollees. Our enrollees actually elect 2 of our board members, resulting in a strong consumer voice. Part of our mission is to protect the safety net. When Medicaid managed care began, there was fear that FQHCs and public hospitals would lose out. Through several strategies, over 20% of LA Care's enrollees have safety net providers as their primary care home. In Los Angeles, large numbers of people will remain uninsured under even the most ambitious health care reform proposals, and the safety net will continue to need our support. Local public plans like LA Care protect consumer choice. Since we started, 3 private health plans serving this population in Los Angeles have gone out of business. LA Care's stability has ensured that Medicaid beneficiaries continue to have continuity and choice. Local public plans raise the bar on performance and quality in their local communities. LA Care offers a steady calendar of provider education, opportunities that improve provider practices and quality of care. Our Family Resource Center serves over 1,200 people a month, most of whom are not our plan members. While defining a public plan option is still underway, we recommend against creating a monolithic national public plan. Healthcare is and will continue to be delivered through local markets, which vary in terms of population and competition, infrastructure, community need, and medical culture. California recognized years ago the need to lower costs and improve quality, and developed local plan options for Medicaid that have been supported by each successive administration, both Democrat and Republican. With regards to the health insurance exchange, LA Care supports allowing states to create their own exchange. We appreciate the recognition that Medicaid beneficiaries have special needs and so are not included at first. However, we strongly recommend excluding Medicaid beneficiaries completely, as they are among the most vulnerable to care for and present unique challenges. California's local public plans are a successful local model that should be considered. Let's build on what's working in healthcare and focus on fixing what's broken. Thank you.
Thank you. Now, let me mention that we do have votes, but I'd like to at least get one or possibly two of the testimony in. So let's see how it goes. Ms. Pollitt's next.
All right. Thank you, Mr. Chairman, members of the committee. First, I'd like to congratulate you on the Tri-Committee draft proposal. It contains the key elements necessary for effective health care reform, and this time I'm sure you're going to get the job done. The proposal establishes strong new market reforms for private health insurance with important consumer protections, a minimum benefit package, guaranteed issue, modified community rating, elimination of pre-existing condition exclusion periods. These rules apply to all qualified health benefit plans, including those purchased by mid-size employers with more than 50 employees. Today, mid-size firms have virtually no protection against discrimination when a group member gets sick. Premiums can be hiked dramatically at renewal, forcing them to drop coverage, and with no guaranteed issue protection, finding new coverage is not an option. I commend you for not including in the bill exceptions to the employer non-discrimination rule that would allow employers and insurers to substantially vary premiums and benefits for workers through the use of so-called wellness programs. Clearly, wellness is an important goal, but ill-advised regulations issued by the Bush administration cynically hid behind it to allow discrimination against employees who are sick through the use of non-bona fide wellness programs that penalize sick people but do nothing else to promote good health. Another good feature of the Tri-Committee bill is the requirement of minimum loss ratios of 85%, which will promote better value in health insurance. The bill grants broad authority to regulators to demand data from health plans in order to monitor and enforce compliance with rules. And it creates a health insurance ombudsman that will help consumers with complaints and report annually to the Congress and insurance regulators on those complaints. Another key feature in the bill is the creation of a health insurance exchange, an organized insurance market with critical support services for consumers. The exchange will provide comparative information about plan choices and help with enrollment, appeals, and applications for subsidies. The exchange will negotiate with insurers over premiums to get the best possible bargain, and importantly, consumers and employers who buy coverage in the exchange will also have the choice of a new public plan option. I know you've talked today about the cost containment potential of such an option. It's also important that a public option would offer consumers an alternative to private health plans that for years have competed on the basis of discriminating against people when they are sick. Just last week, your committee held a hearing on health insurance rescissions that discussed people who lost their coverage just as they started to make claims. And at a Senate Commerce Committee hearing yesterday, a former officer of Cigna Insurance Company testified on common industry practices of purging employer groups from enrollment when claims costs get too high. I would like to submit his testimony for your hearing record today. When consumers are required to buy coverage, having a public option that doesn't have a track record of behaving in this way will give many peace of mind. And I left the rest of my statement in the folder. Isn't that terrible? There we are. I got it. I'm so sorry. Second, a public plan will promote transparency in health insurance market practices. In addition to data reporting requirements on all plans, with a public plan option, you will be able to see directly and in complete detail how one plan operates, and if private insurers continue to dump risk after reform, it will be much easier to detect, and sick people will have a secure coverage option while corrective action is taken. Mr. Chairman, in my written statement, I offer several recommendations regarding the draft bill and will briefly describe just a few of them for you now. First, the benefit package. The benefit standard in your bill does not require a cap on patient cost sharing for care that is received out of network, and it really needs one. Also, the benefit standard does not specifically reference as a benchmark the Blue Cross Blue Shield plan that most members of Congress enjoy. Many have called on health reform to give all Americans coverage at least as good as what you have. It's not clear whether your essential benefits package meets that standard, but if it doesn't, it should. And if that raises the cost of your reform bill, it will be a worthwhile investment to raise that standard. Over the next decade, our economy will generate more than $187 trillion in gross domestic product, and we will spend a projected $33 trillion on medical care. The stakes are high, and it is important to get this right. Second, rules governing health insurance must be applied equally to all health insurance. As drafted in your bill, some of the rules that will apply in the exchange might not apply outside of the exchange. Further, there's no requirement that insurers who sell both in and out of the exchange to offer identical products at identical prices. If the rules aren't parallel, risk segmentation can continue. As an extra measure of protection, the Tri-Committee bill provides for added sanction on employers if they dump risks into the exchange, and similar added sanctions should apply to insurers. Another problem with non-parallel rules is the exemption for non-qualified health benefit plans and limited benefit policies called accepted benefits. Healthcare reform is your opportunity to end the sale of junk health insurance, and you should do it. And finally, Mr. Chairman, with regard to subsidies, the bill creates sliding scale assistance so that middle-income Americans with incomes up to 400% of the poverty level won't have to pay more than 10% of income toward their premiums. But as charts in my written statement show, some consumers with income above that level could still face affordability problems, especially those who buy family coverage and baby boomers who would face much higher premiums under the 2-to-1 age rating. I hope you'll consider phasing out the age rating and also setting an affordability premium cap so that no one has to spend more than 10% of income on health insurance. Thank you.
Thank you. I don't want to cut you short, Ms. Ignani, so you can all wait until we come back. Well, hopefully we won't be too long. I'd say, what, 20 minutes or so? Thank you.